Good morning, everyone. Welcome and I'm very happy that you all joined our session about intravascular lithotripsy. During the next hour, we will have the opportunity to discuss the mechanism of intravascular lithotripsy. We will talk about the practicalities, how to use intravascular lithotripsy, and we will also have the opportunity to discuss how to use intravascular imaging to guide these procedures. And for all this discussion, I have the pleasure to have here a good panel of Dr. Weinstein, Dr. Punamiya, Dr. Tam, and Dr. Tan. We will hear some lectures, but we will have definitely a lot of time for discussion within the panel. But I would like to also ask you to use the app or just stand up and go to one of the mics and make your comments, make your questions, share your experiences with us in order that we can all learn as much as possible about the use of device in clinical practice. So with this start, I would like to right away hand it over to Marco to talk about the science behind this technology. And again, please use the mic, use the app to make your questions and comments. Marco.
Okay. Good morning, everyone. I see some friends here in the audience, and it's been a privilege for me to be back to Singapore. And thanks to Shockwave for this invitation. And also thanks to my friend Mike Lee, that used to be a fellow with me a long time ago in Boston. And now I heard he's going to be the new president of the Asia Society of Cardiology, Interventional Cardiology. So congratulations for you guys, because Mike is a special, very special person. So my task is to give you some tips and hints about the science behind intravascular lithotripsy. I'd like to start with the obvious but important concept that the severely calcified coronary lesions are still an unmet clinical need. And why? Because we know that they increases the safety risk of the procedure, they impede stent deliverability, and also they prevent stent expansion, increasing the underexpansion, which is associated with the increase of ischemic events. In a meta-analysis with more than 6,000 patients, we can clearly see when we compare the red color with non-severe calcified to severely calcified in blue lines, that there is twice as much chances of having a severe adverse event, and you have a severely calcified stenosis when you're dealing with severe calcified lesions in PCI. So basically, lithotripsy for cardiovascular applications is relatively new, but in terms of other uses, it's been quite old. It's been used for over 30 years, for example, for treating kidney stones, as you all know. So how it's the Shockwave system? It basically consists of one generator, is a portable generator, the connector cable, and the balloon catheter. There is a rapid exchange over the, all 14 inches a wire compatible system. The balloons go from 2.5 to 4.0 diameters, and they all have 12 millimeters in length, and they all have 2 emitters that are responsible to pulse 1 per second from 8 to 120 pulses, depending on the balloon. The C2 balloon has 80 pulses, and the C2 Plus has 120 pulses. And basically, this is a cartoon that shows the intravascular lithotripsy procedure overview, but you can see better in this animation here. Unfortunately, the sound is not going on, but it's not. There should be some animation here and sound with this, but it's basically showing the vessel being achieved, the lesion being achieved by the balloon in the system, where after the balloon is expanding, there is a vapor bubble that creating a short burst of sonic pressure waves. The sonic pressure waves travel through the vessel with an effective pressure of 50, equivalent to 50 atmospheres, and a localized field effect within the vessel fractures both superficial and deep calcium. Probably one of the most striking and interesting feature of the intravascular lithotripsy is the concept of hard on hard and soft on soft. As you can see here, there is a large difference in density between the fluid in the balloon, and the gypsum causes the calcium material like to fracture. But when this is applied to water or a fluid or some fluids, the sonic pressure safely propagates through the soft tissue, causing no damage at all. So this is, I think, it's a very important concept. And here you see another animation showing that the high-speed shock waves are created safely and inside the integrated balloon, and there is unfocused shock wave energy, and then this electrical energy is delivered to the emitter, initiating the steam bubble, which expands and collapses, creating sonic pressure waves. Intravascular lithotripsy has been an adaptation from other systems, and the Shockwave system utilizes electric hydraulic lithotripsy with several adaptations to achieve safe and effective treatment. The waveform modification is integrated from the IVL balloon and with the emitter aligned. I think this cartoon shows better how exactly intravascular, which is the mechanism that lithotripsy causes the calcium fracture. There is, first of all, compressive stress, causing compressive at the leading stresses at the leading edge. Shear stress generated as shockwave propagates. Small and tensile stresses, partial wave reflection at the rear reverse pressure creates pulse and tensile stress effect. And finally, and more importantly, squeezing stress. The shock waves travel faster within the calcium, and the wave speed is faster in higher density medium. So compression, shear stress, tensile stress, and squeezing stress. Be aware that very often you don't see the fractures, even using OCT, but in about 57 to 60% of the times, even when you have effective fractures, you don't see them in regular imaging systems, but they are there almost in the vast majority of the cases. So in summary, calcium is likely the main obstacle for a successful PCI due to its causing limited stent deliverability and further expansion, potentially resulting in thrombosis and restenosis. Shockwave IVL emits sonic pressure waves that travel through the vessel, representing an effective pressure equivalent to 50 atmospheres. Shockwave IVL fractures both superficial and deep calcium, and the sonic pressure waves cause no damage to soft tissues due to the minimal difference in density. With that, I think we can continue and present the next talk. Thank you so much.
Thank you very much, Marco. One question which I've seen you mention that on imaging, you can just on imaging, in 50% of the cases, you don't see the fractures. Still, we like to do that, or we like to say and practice that after lesion preparation, you use imaging to confirm that you did something. So you do shockwave, you do imaging, you don't see the fractures. Still, can you trust that now the lesion is prepared enough for going on with other modalities, even if you don't see the fractures, or how do you use it in practice?
Well, this is a very, very good point. To be very precise, if you don't see the fractures, one could say that if the fractures are not there, it simply didn't work because you're using something to cause the fractures. But as I just showed to you, in about 50 to 60% of the times, you don't see them at all, even in the OCT. And I was even less, more than 70%. So if you did a good job using the balloon and choosing the right sizing balloon 1-to-1, I think in most of the times you can believe that the fractures are there and you simply are not seeing them.
So then, for instance, balloon testing could be a good approach.
Yeah. You can, if you're not completely sure, before in between the shockwave use and the stent implantation, if you're not using DCB only, because sometimes you use DCB only. It's another discussion that we might have at the end. I think it's a very good combination, DCB only after Shockwave. But if you're going to stent, you can test with a cutting balloon or a regular non-compliant balloon and see if it's fully expanded.
We have one question from the audience, and it fits you also because of the technicality. Is the balloon of the IVL non-compliant or semi-compliant? Does it even matter at the pressure of 4 to 6?
It's a semi-compliant balloon, but it really doesn't matter because you only inflate the balloon up to 4 atmosphere. Then you start with metals, and during the 10 seconds is 1 pulse per second. You keep the balloon inflated at 4 atmospheres only, and then after it finish, for a few seconds, they want to keep it for 6 atmospheres, and you go down. So the compliance of the balloon is not the main point. It's going to be equivalent to 50 atmospheres anyway.
And actually, I believe that the main goal is anyhow the nice wall contact all over the balloon, and therefore a semi-compliant structure fits better to the concept.
There is a multivariate analysis that was made when they pull all the disrupt trials, and when they look to all the variables, all cracking or not cracking, fractures or not fracture, size, everyone. The only feature that was responsible for a good stent expansion was a successful one-to-one full delivery of the emissions. So you have to choose the right balloon and keep it there in the right spot, the 2 emitters right in the center of the lesion, and one-to-one. Should we continue? We have time for...
Yeah, we have time, I think, for a few more questions from here.
What's the failure rate of IVL? Is someone want to talk about that? Someone is asking...
How often do you fail with IVL?
So IVL is a fantastic strategy, especially the live cases when you saw calcium so often. I think the beauty of IVL is that it's simple, safe, and very stable the patient. The main downside is that you can't deliver it. So I think as long as you can deliver it, the success rate is extremely high, provided you prep it properly. The main reason for failure is that you underestimate sometimes the angulation and bulkiness of delivering the IVL. So the trick to our successful IVL strategy is to make sure that you can have some support, particularly with a guideliner type of tech, to bring the IVL balloon to where you want to deliver it.
I think we have to continue, right? Can I call for the next speaker? Then we're going to have more time. And please continue with sending some questions. Dr. Tam, it's my pleasure to invite you to speak now about cracking nodule calcium.
Yes, can I have my slides? So thanks, Chairman, for your kind introduction. So I'm Frankie Tam from Hong Kong. So thanks, Shockwave and organizing committee for letting me to be here. And thanks for entering Hong Kong some time ago. So I'm happy to use this nice technology for some years so that I can share my humble experience to you all. So today I would like to talk about how Shockwave actually acts on nodular calcium. So nowadays we know that lesion preparation is very important for chronic calcification. And nowadays in our lab, we have different types of armamentarium, ranging from balloons to different sort of atherectomy laser. And obviously, very important weapon is actually the IVL, the lithotripsy. So today my topic is mainly for calcified nodules. So nowadays we know that the formation of calcified nodules usually start from some calcified plaque, some sheets of calcium, particularly in the tortuous area, that the hinge motion will increase the injury of this calcium, which makes the formation of calcified nodule. So obviously, the most common site of calcified nodules is actually in the proximal to be RCA, and secondly will be the LAD. And thanks to the work of Dr. Akiko's work, nowadays we know that from intracoronary imaging, we understand that for calcified nodules, there are different types and different morphology. And basically, the more important types are actually the eruptive calcified nodules and the non-eruptive calcified nodules. And from the studies, we know that for eruptive calcified nodules, like here, there is some irregular surface. It is more aggressive from an electrocardiographic history, particularly it's for those on dialysis, right? Renal failure patient, this eruptive calcified nodule is very aggressive. For the acute results, they have better response to atherectomy in the balloon and better expansion. But for the clinical point of view, they have worse medium and long-term results because these calcified nodule, eruptive one, can ingrow into the stent again. In contrast, for non-eruptive calcified nodule, the surface is smooth, right? They're round, but they are more resistant to atherectomy and balloon, and they have worse stent expansion on the acute PCI results. But for medium to long-term results, they are better when compared with eruptive calcified nodules, right? So before I go on to how do we treat calcified nodules, we have to define what actually is the successful PCI for calcified nodules, right? What we are talking about, is it acute procedural success? For example, is it the nodule volume reduction, the nodule compression, or the cracks or fractures seen on OCT or micro CT, or is it the luminal gain? Or is it just the minimal stent area, the percentage of stent under expansion, or stent eccentricity? Of course, we can also talk about whether this talk about the medium to long-term outcome, right? This is more like patient-oriented, that is the MACE, or device-oriented, that is the target lesion failure, right? So before we talk about PCI to calcified nodule, we have to define what do we mean by success to PCI for calcified nodules. As I've mentioned, the eruptive calcified nodules, acute procedural success, they are better when compared with non-eruptive one. But of course, as I've mentioned, for medium long-term outcome, they are worse because the calcified nodule can ingrow into the stent again. For non-eruptive calcified nodule, this is the worst for acute procedural success, but better in medium to long-term outcomes. So basically, the strategy for PCI to calcified nodule, there are several ones. For example, some can use balloon or cutting balloon. So for balloon, is mainly the effect is mainly by compression, the section along the edge, stretching the normal tissue. But for IVL, it's better because IVL, as the previous speaker has mentioned, it can generate very high stress by different mechanism, so that it may create cracks, right? Also, at the same time, create some nodule compression, the section and stretching normal tissue. On the other hand, for calcified nodule, atherectomy is also very useful. For atherectomy, be it rotor ablation or orbital atherectomy, it aims at ablating the calcified nodule, that is volume reduction without cracks. But of course, we have to know that for atherectomy, wire bias is very important, right? If the wire bias is not at the nodule side, no matter what we do, it's actually not doing much on the nodule, but injuring the normal tissues. For some cases, actually, we have to use combination of these technologies for us to achieve the best outcome for our patients. So we will talk about Shockwave IVL to calcified nodule. On the literature, there are not many studies, but there is some evidence. This is the study by the Zayat group and also in the study by Gupta's group. Actually, it shows that for IVL to calcified nodule, they can achieve similar stent expansion, similar minimal stent area, and acute gain. At the same time, for this study, we can also see that for IVL for calcified nodule, we can see cracks or fracture in 70% of the time, right? And most of the time, this fracture occur at the base of the calcified nodule, that is in between the nodule and the normal tissues. And many times, we can see this on the intracoronary imaging, especially OCT. Besides crack, right, as speaker mentioned, there are also some possible mechanisms how IVL can work in calcified nodule. One is the microfracture, as seen in the micro CT. Another one is actually the compression, right? There's an interesting study published in JACC Intervention, the imaging by Dr. Huang's group, right? On this imaging, they propose that actually IVL can have some degrees of calcified nodule compression, as shown by the intracoronary imaging, such as OCT, and also the stent boost. So besides visible fracture on OCT, microfractures on micro CT and calcium compression may explain partially the efficacy of IVL on calcified nodules. So next, I will show you some two cases on how I use our IVL in calcified nodule. The first one is a 73-year-old man, hypertension, smoker, and STEMI. Coronarogram shows RC and LAD disease. We have performed the PCI to LAD and D1. This is the stage PS to RCA. We can see a lesion at the proximal to mid RCA here. And intracoronary imaging of the OCT show this eruptive calcified nodule here, right? So in this case, there are many ways to treat that. In this case, I choose to use IVL. So as previous speakers has mentioned, for efficacy of IVL, especially for calcified nodule, right, we have to use 1-to-1 sizing and deliver as many pulses as possible. So in this case, I use a 4.012 IVL balloon in here for X cycle. You can see the balloon actually expands better after this X cycle. And on the OCT, interestingly, you can see what we may be able to see on OCT for this calcified nodule. There is some fracture here, and also fracture at the base, that is in between the nodule and the normal tissue. At the same time, you'll be able to see some compression of the calcified nodule, right, as opposed to what happened before the IVL. And at the same time, you can also see the lumen gain, right? Before that, the lumen is just 2.92 millimeters square, but after the IVL is 8.06 millimeters square. So fracture, compression, the section along the edge, and also the lumen gain. This is how we can use intracoronary imaging, especially OCT, to visualize the efficacy of IVL on calcified nodule. In this case, stenting, post-dilate balloon, this is the final result. We can see now the MSA is very good, 10.54 millimeters square, and the stent expansion in more than 100%. So this case showed the efficacy of how we use IVL on calcified nodule. The second case is more complex. So the 72-year-old man, hypertension, AF, with CABG done before, right? 3 vessel CABG, this time admitted for STEMI, angina. Angiogram actually shows native TVD, LAD CTO, patent LAD, SVG to PDA, and also the block SVG to OM graft. We can see this is the angiogram. We can see a tight lesion with distal left main to the osteo, to proximal and mid circumflex, very calcified, and I believe these lesions can account for the patient's STEMI and symptoms. So how can we treat this lesion? So we start with intravascular imaging. We try to pass on the IVUS, but obviously you can see the IVUS cannot go down. So when the imaging catheter cannot go, sometimes you'll be able to use atherectomy. So we start with a Rotapro 1.5 burr. You can see we start it very slow. You can see we do it bit by bit in the mid circumflex. You can see there's a tight lesion here. The burr cannot go through. Okay, you can see more rounds of wound ablation. We try to do it slowly. Unfortunately, we push harder. You can see here. Okay, we try to push harder, longer cycle, the burr goes, but again, the burr cannot come back. So this is a classical mechanism of burr, stall, and trap, right? So a classical example, what can we do? What we have to do? So we first try some manual retrieval, right? Pull it gently, but obviously it failed. And then for the trap burr, for the algorithm, there are many ways, right? In this case, we start from the simple one. We use a ping pong guide. We pass a filter wire across the lesion. We sequentially use balloon to pass. We start with 1.0 balloon, 1.5, and 2.0 balloon, and dilate around here, right? And then we can successfully retrieve the burr after this balloon dilatation. And this is one of the very easy method for burr retrieval after the stall burr. Just the angiogram afterwards. Luckily, we did not have any injury to the vessel here. Right? But afterwards, what can we do? Right? The stall burr, what can we do? Right? Should we do another burr again? Should we step down, step up the burr? Should we do orbital? But what can we do is that we can use imaging. So because after the burr and also the IVUS, now we can pass on the, after the balloon, we can now pass on the IVUS to the circumflex. So in this IVUS, we are able to see some calcium, of course, right? And also some calcified nodule in the proximal and mid circumflex around here, right? So in this case, I try to use a Shockwave here. So I pass down a Shockwave 3.012 balloon to the mid circumflex. You can see the Shockwave balloon actually dilates quite well. So this is the angiogram after the Shockwave. And what we're able to see is that the Shockwave in this calcified nodule, we're able to create some cracks, right? And also lumen gain in this calcified nodule in the circumflex artery. So afterwards, some more scoring balloon, and then we put in 2 drug-eluting stents, and this is the final results of this Shockwave to the calcified nodule in the circumflex artery. So ladies and gentlemen, in conclusion, calcified nodules remains to be a challenge in modern PCI. Intracoronary imaging is essential to guide the treatment. There are various devices to treat calcified nodules, and combination therapy sometimes will be essential. Intravascular infiltration is safe and efficacious to treat calcified nodules. So thank you very much.
Okay. Congratulations, Dr. Tang. You can stay on the stage and the podium for some questions. I have myself one comment for you, but I'm going to start from your last case presentation. And it's not because you got a bailout problem to solve with the rotablator that got stuck there, but before I saw that, I was going to make a comment anyway. You try to IVUS and the catheter didn't go, then you went to rotablator, right?
Yes.
This is something that has been in any old algorithm, but this is something that, again, I've been telling all people that this is something that was created before the Shockwave era. In the Shockwave era, you don't need to respect that thing. If the IVUS doesn't catheter or OCT catheter does not go through, you can always try to dig a little hole with a 1.5 balloon, then a 2.0 balloon, and then if you find a space for a 2.0 or even 2.5 balloon, after several dilatations, you can continue with Shockwave. And then probably in this specific case, this would have prevented exactly the burn treatment that you had in this particular case.
Yes, I agree. That makes the case much easier.
Let me ask to you right away, merging three of the questions from the room, because it all fits together.
Yeah.
So, one colleague asks whether IVL will replace rotablator in the future. The other one asks when and how to combine the different tools. So, please, if you could just summarize whether these are complementary tools.
Great questions. I would say I can give a lecture about that, but of course I will summarize this. So I would say it will not replace completely. These two modalities are complementary, I would say, because sometimes we still need volume reduction. In some cases we need volume reduction, that is ablation, right? Be it rotablator or orbital atherectomy. And so I believe these two devices are complementary. Yeah.
Okay. And when you combine them, normally start with rotablation and after that IVL, or is there also cases when you think that after IVL a nodule was not perfectly modified and then you switch back to rotablator with large burr?
Yeah, I would say most of the time is rotablation and IVL. But in some cases, which is off-label, I would say, for those cases in-stent ISR, right? In those cases, you may try to use IVL first, and then sometimes, because IVL can break the calcium outside the stent, yeah. But for those, the calcium distal to the stent or calcium inside the stent, sometimes maybe a rotablation is better.
With all due respect, I disagree with you when you say that. I think IVL is going to totally replace rotablator in the near future. I still think we use a lot of rotational atherectomy for real uncrossable lesions. It's my only indication that I combine both. But with the new catheter that the Shockwave is bringing in the next 1 year or so, that's going to be able. It's a micro catheter that is going to emit sonic wave pressures to the lesion after you cross the wire, and then the uncrossable lesion is going to turn to be crossable. I think the days of rotational atherectomy are gone.
Yeah, we are looking forward to that. Yeah, forward, yeah, Shockwave. Yeah.
Thank you. And with this one, I would like to introduce you, Dr. Punamia, to present actually the practicalities of the use of IVL, more pulses in more complex calcium. Is it the right way to go?
Kirti Punamia, yeah, got it right. Thank you so much. I'm going to go straight into my case, which is a 73-year-old German, effort angina, risk factors are hypertension, and a strong family history. 2D echoes are good. For me, imaging starts before we get to the cath lab, and primarily in the CT. And our CT scans actually tell us the distribution of calcium. And almost kind of before you go into the cath lab, you know pretty much what you're going to face and the tools that you might require to kind of conquer that. This is the angio. The LAD seems long, diffuse, calcified. You can see the diagonal branch has some disease. The circumflex is a little mildly tortuous with two S bends, and disease going on that bend, heavily calcified. Further on disease beyond it, going into that OMPL branch. What is the plan? The plan is to do a PCR to the circ, follow it with a PCR to the LAD, and the challenges in calcium lesion for me are just two: crossability and expansibility. Moderate calcified circumflex, we start. I was difficult to cross, so we go ahead with the microcatheter. Microcatheter does not cross. A small balloon does not cross. So yes, the microcatheter will cross. So we have two choices: rotational atherectomy, orbital atherectomy. If it didn't cross, for me, ELCA or a tornus are the other options. In this case, we chose the orbital atherectomy. We chose the 1.25 crown, and you can see we start slowly. With a dynaglide, you can actually go beyond and then ablate on the way back, and that's the advantage. 5 runs down, you can see that there's a free mobility to the crown, and we almost always do a reverse retrograde ablation with this. It has an advantage over rotational atherectomy because in these bendy circumflex arteries, as shown by Jackie, you could avoid the nightmare of a stuck burr, and this is a great technology for that. Of course, then the IVUS catheter grows. So we've done the crossability. We've been able to get a crossable IVUS catheter there, which allows us to go into imaging, which tells us there's a diffuse, long calcified lesion there from this run. And if we break it up, a distal landing zone is approximately a little around 275, maybe 3. Proximal landing zone is 3.5, and they're 42 millimeters apart. So that's a pretty long lesion in that circumflex. If you look at what we achieved, the MLA that we achieved with the rotational atherectomy was 2.68, and that was the minimum that we had. We had a ring of calcium. Now, how do we go beyond this? So how does imaging help us in layering the next tools? There are only so many tools that we have actually for calcium. The question is, how do we play around with them? And so for me, it would be, if this is a 3.5 proximally, then I'd go a little undersized, put a size down with a Wolverine, see if it can go up to 16 to 18. And then if there are areas of inexpansion, then of course in circular calcium, more than 180 IVL would work, and even otherwise, I think that would be my choice. So we dilated the circumflex with a 3.25 by 6 Wolverine, and we found that this was the area which failed to expand. All the other areas kind of expanded pretty well. So what it tells us, it's amongst that long diffuse calcified lesion, it kind of pretty well predicted the area that is resistant to expansion. So that's where we took it at 3.5, 1:1 size, IVL balloon, and this was the C2 plus, and expended 60 pulses to achieve complete radiological expansion, which is determined by the balloon inflated in 2 orthogonal views of fluoroscopy. This was the strategy, and you can see that circular calcium there cracks. IVUS shows and demonstrates multiple cracks in that area, expansion of the MLA. And it tells you that now you're ready for a stent delivery, which we did 2 stents downstream into that circumflex. And the IVUS showed that we had to optimize it with further dilatations to achieve our optimal MSAs. We move on to the LAD. Again, we find that it's difficult to cross, and the IVUS catheter struggled at this point. But we got the images from as far as it went down to tell us that we're dealing with a very diffuse calcified lesion, which we knew from the CT anyway. Microcatheter crossed. We had the orbital atherectomy on our table, so we used it. No point in looking for other tools. 1.5 again. And this is the orbital atherectomy runs. Around 3 runs were enough. We did the last one with 120. And this is post-atherectomy. The IVUS post-orbital atherectomy kind of clearly defined series of sections. And for me, I quickly had to analyze those ones which are in the distal segment. This artery was around the EL to EL was the luminal diameter at the landing zone was 2.9 millimeters at the distal end. So we knew that it's distal 3 and then it grows proximally. So an extensive diffuse calcified lesion. For me, these yellow boxed lesions, I mean, a Wolverine would work based on these IVUS images, a trio. And in these lesions, dense calcium all around, I think I may need an IVL. And if I have one on the table with 60 pulses to spare, then that strategy allows me to use this IVL in that restricted area where I'll have in expansion rather than wasting out on the entire length. So I start off with my Wolverine, and I find that it expands completely except for that one area a grain in the proximal LAD, as shown on this right image. This expands well, this does not. You can see that inexpanded at 18 atmospheres, the Wolverine. It tells me this is where I need to get my IVL. So the IVL which I have, spare 60 pulses, I expanded in that proximal LAD, achieve complete expansion, again radiological. And this is post-IVL. It shows improved MLAs, it shows calcium fractures, it shows all those things which make me think that we've prepared the LAD well. So on the IVUS, we come back to the ostium. The question is, do we kind of involve the ostium in that stent placement? And this ostium of the LAD tells me that I'll have to do a left main to LAD crossover, given that my circumflex ostium was okay. So this is a comparison from image to image based on landing zone 2 timed on the IVUS. You can see the relative expansion and the fractures created by the IVL expansion, by the IVL balloon. And it almost tells us that this LAD is now ready for stent delivery. So we used, our first stent went in from the left main to the LAD proximal there. Last stent, we did a pot with a 4.0 based on the IVUS size. We went with the pot. Determined again that the pot was adequate, expansions were complete. We then optimized the proximal LAD with high pressure balloon dilatations with a 3.5, and then put in our second stent downstream in the LAD. We did an IVUS and made sure that our MSAs were matching the size of the stents that we predicted there, and concluded the case. Navigating calcified lesions are often challenging, need us to overcome two basic issues in calcium. Layered approach using multiple devices is often required to tackle most calcified lesions. IVL Shockwave C2 device with 120 pulses has been rather helpful, because in previous times we've had to move to 2 balloons, which is rather expensive, and rationing the energy to treat multiple lesions in a given patient is possible. Imaging is the key in defining and predetermining the segment where the shockwave energy can be then focused, so that you use these expensive tools rationally. Thank you.
Thanks for your excellent presentation. You can also stay, and there is one question from the audience, I think, also relates to your presentation. You might address, and we can discuss later too. The question is there a role for IVL in underexpanded stents? I think he is mentioning both immediate underexpanded and then late underexpanded with restenosis. So do you want to address this?
I am hearing an echo, so can you repeat your question in the mic?
There is a question about the potential use of IVL for underexpanded stents.
Right. So yes, IVL can be used for underexpanded stents, but I think we might have a technology in excimer laser to use for underexpanded stents as well. I think it's an area which needs a lot of work, and I would love to see some data showing one better than the other, but we have maybe these two technologies at the moment.
Good, maybe one question. You mentioned that complex lesion, more pulses, very good. But you have one focal lesion. It's one lesion for the patient to treat. Do you routinely give all the pulses? Why not? It's already there, the balloon is opened. Or you just go by visual and you give as many pulses as you see that the balloon opens, and then it was enough?
So here, if I was dealing with a single isolated lesion, I'd give as many pulses that I need to achieve expansion and then come out. I truly believe that you don't want to be in the coronary more than you need to be in the coronary. That's one. So, but you need to give enough to have achieved why the IVL balloon has been put in there. And for me, that comes with me being satisfied with the expansion that I see fluoroscopically. The problem in pulling back this balloon and trying to negotiate back is that it does lose profile, and you don't want to do that if you don't have to do that. So one way would be to take it out, do an IVUS, and see if you've done enough, and then go back. Don't do it. Put in an extra train or two and come out. And what is the worst case scenario is take another balloon, right? But if you can ration And if you can kind of, you have 120, 120 pulses, so you can kind of more or less figure out how you need to distribute them in these diffuse complex lesions.
What do you think, what is the minimum pulse what you in one location needs to give that it works?
So we looked at our data. We looked at 3 years of data of IVL, and we're actually analyzing that. And if I were to cheat and tell you what we found is that approximately 15% of our patients will dilate within the first strain. 15. Around half our patients require at least 30 pulses to kind of get optimal. But we've had patients where we've expended 120 and not achieved anything. We've had approximately 4 such cases in our small series, but yes, that is also possible.
You want to make some comments?
Yeah, you were very fortunate to be able to use the same balloon in the 2 vessels, because usually when you open the balloon in one vessel, take it out of the body, it's kind of difficult to reuse in a different vessel, right? This is
So I think that's where I kind of differ with you on your earlier comment of making atherectomy devices a little obsolete in the near future. And I think, no, they will have a role, and I think they are here to stay, in my opinion. Unless something really dramatic comes up with the next balloon, I think that ablative, exercise on that calcium does improve crossability for bulkier devices, particularly already used IVL in another artery. If you have to kind of take a second artery, might make it a little easier to negotiate.
Yeah. Maybe I can ask a quick question. Curti, you're a big imaging guy, so I see all your complex lesion done perfectly with imaging. In this part of the town, imaging is limited, but IVL is quite easy to use. So in what circumstance would you pull out an IVL without imaging then? Yeah. What? Just angiographic?
Would I use IVL without imaging? I don't see the point, really. Cost cannot be a issue, because you're already using a very expensive tool. And when you're using a very expensive tool, it is also okay to use a less expensive imaging guidance to make sure that you've used that tool appropriately, effectively, and got the desired result at the end. So I just don't see the reason why we should be doing very complex lesions with our eyes shut. So imaging is the key, I think. It tells us where to focus, and it also tells us whether we've achieved what we desire to achieve.
There's one question from the audience, and I can turn to you here. The colleague asked about perforation rate with IVL in clinical practice. Have you ever seen, experienced perforation coming from the IVL?
Yeah, my experience, no. I have a case of perforation, but it's not due to IVL. So in that case, we use rotablator, IVL, and then the scoring balloon. The perforation actually comes after the scoring. So I think this perforation, but I don't think that's related to the IVL.
Same experience. The perforation can always happen in such complex lesion with a lot of calcium. My personal experience, it always happens if you tend to have not prepared the lesion well, put in a stent, some form of minor stent regret, go too aggressive inside the stent for post-dilatation. Most of the time, that's when perforation, not with the IVL balloon.
I think it's a very good point, because everyone is afraid of perforation during advanced lesion preparation procedures. However, if you are not preparing the lesion well, if you just go by balloon, if you just put a stent and want to post-dilate, this is the cases when the perforation and rupture happens, I believe.
So,
Common with OPM balloon inside the stent. Yes.
So I have a comment, on the preparation bit. I think sizing is the key. If you're going to go up to sustained high-pressure devices like the Wolverine or an OPN balloon, I think the key is to size it appropriately. And if you see eccentric calcification with a normal segment, it's safer to undersize. And I think that's the key. That's the only.
Thank you very much. So with this message, I would like to thank you for coming. Summarizing what we discussed during the last hour, actually, that IVL is definitely one of the new tools in calcium preparation. It should be considered as one of the tools what we have in our hands. What often, as just was demonstrated during the cases, needs to be combined to achieve the good results. Imaging is your guidance to understand what you have to do, what you have done, and whether you did it properly. And if it's in the right hands and right experience and chosen well, then it seems to be a very safe procedure. Thank you very much, and enjoy the rest of the meeting.
Thank you.